Facelift results, simultaneous volume replacement and laser resurfacing. So Alex, you're up when you're ready. All right?
I want to thank Dr. Gold also for inviting me again this year. It's a wonderful meeting, and I'm really honored to be here. So I want to talk a little bit about optimizing facelift results, so how I combine the surgical side of what I do with similar things to what really all of us do, which is the rest of the non-surgical rejuvenation. Fat transfer is what I want to focus on as far as the volume replacement in this talk. A little bit more of a surgical procedure, but it's something that all of us can incorporate, and hopefully some have. It's a very good value procedure, and it's well suited for the right patient, as we'll talk a little bit more. Really have no disclosures that are pertinent to this talk. I'm going to be focusing on non-synthetics. So I'm really passionate about volume restoration, and as a result, I've written a little bit about it with the fellowship mentors of mine as well. One of the figures I like most is the split face, which kind of shows you, a lot of us have seen these, so I won't belabor it too much, but the volume loss in the periorbital area is one of the things I really like to focus on, which itself I think causes some descent to the brow. But the atrophy that occurs, soft tissue and bony, in both the upper and lower periorbital areas and lateral canthal area contribute to this aged appearance. Not much descent to the brow, though, is one of the things I like to point out. And of course, the typical nasal fold formation, pre-gel sulcus formation, and marionette. So a female, through the aging process, shows bony expansion of the orbital rim through atrophy, and also loss of soft tissue in the same areas. And one of the key things about that, I think many surgeons are too apt to do brow lifts for a couple of reasons. One is this bony expansion causes elevation of the sort of the target that we're striving for when we're talking about the ideal position of the brow. So the brow, we all know, is said to be supposed to start and end on the bony orbital rim. Well, that becomes a bit of a moving target because of this bony resorption phenomenon. So you can chase the bony rim all the way up the forehead, not all the way, of course, but you can chase up the forehead somewhat and end up creating a little bit too elevated of a brow. And I think more of the Facial Plastics Academy is beginning to embrace this. In fact, just a couple weeks ago, we were speaking in Nashville, and on one of the panels, someone presented a brow lift patient combined with some other procedures, and actually a past president called him out on what he thought was a bit of an over-elevated brow. So I was happy to hear that, and while it was a bit of a shock to hear someone call it out in the middle of the presentation, I think it's nice that the Academy is embracing more conservative brow lifting procedures if they're going to be done. In fact, much of what I do, if I do an endoscopic lift, is pretty limited, and I like doing the tail of the brow lift more than the rest of the brow in general. So that's one of the things, the bony resorption, and I think the other thing is the optical illusion that is created when we lose the volume in this area. We create a shadow there, and that shadow, the brain perceives a dark object. I was reading up on some psych literature, and it seems that a dark object as opposed to a bright object will be perceived as smaller volume or smaller size. And so I think that when we see this, we think that this distance is smaller and needs to be enlarged. And so a brow lift, she clearly already had one done, but if you see this here, I think someone might say, well, maybe that's why she didn't appear, because someone said that darkness or that area there is too small, so we need to raise that up, or we need to get this up higher on the orbital rim. Regardless, I think there's a bit of an optical illusion that occurs when you get that shadow effect. The other thing is that people may want to have a certain amount of highlight beneath the brow, and instead of creating that by restoring volume, I think that by lifting the brow, they're exposing more of that higher orbital bone, and thus creating the highlight that they were looking for. But what I've enjoyed doing over the past few years is starting to do more and more filling of that supraorbital rim to achieve that highlight without altering the position of the brow itself. And I just would encourage everyone to look back at pictures of babies and look at how low their brows are and decide for ourselves if they need a brow lift. Probably preaching to the wrong crowd, but regardless, you can certainly see the younger patient has a lower brow than the older patient. So it's not necessarily an aging phenomenon to have a lower brow. Guys, of of course, go through the aging process in a similar way with volume loss and deflation of the mid-phase and exposure to infraorbital fat pads and the like. And interestingly, also, not much descent to the brow. So with fat transfer, this is a typical patient that would come in. She actually had a mini lift done elsewhere and was still not thrilled with her appearance. And didn't know for sure what she wanted to do. So we talked about fat transfer. This is not her, but these are the typical zones. This is how I typically mark it out. Upper orbital rim, supraorbital rim, and this is for blepharoplasty on a different patient. But so I don't fill that area right on the lid itself, but the subbrow skin. The temples, I frequently blended the temples more and more now. The infraorbital rim, I spent a lot of time on, and then the anterior and lateral cheeks are some of the common things that we do. And in this particular patient, I felt like we got a pretty decent result by doing volume restoration. In this case, she had, I would say, moderate to advanced atrophy. And so, and I'll show a couple of examples of what the various amounts of fat are that we used. But so this is kind of a moderate to advanced one. In her case, we did do the supraorbital rim, and I put a cc of fat medially and then 2, I consider this lateral, so a total of 3 cc's along the supraorbital rim. And in general, it's about 3 times what I would do with an HA filler, it seems. And of course, all that doesn't stay, so the net effect, as I'm saying, is probably about a cc. So 3 cc's along the infraorbital rim, 3 in the anterior and lateral cheek, and then I did some lower periocular treatments as well. And just a little close up of the eyes, how, as Mark Glasgow would say, how springs the eye when you restore volume around it. Let's see. This one I had not yet, I don't think, but interestingly, she did want me to do a revision rhinoplasty, and I did that later. So I don't know if that's in these pictures or not, but we did raise the hanging columella there. We actually lowered her alar retraction. So, but she did actually, so I did fat transfer on her after a very kind dermatology colleague of mine referred her to me, and then sent her right back and she had laser resurfacing with him. So nice symbiotic relationship. So that's why our skin looks so much better. But as we will talk, I don't think this was quite a year out. The subsequent one is about 4 years out. You actually do tend to see a little improvement in the skin. We tend to see a lot of it. And it's debated exactly what the cause is. But at any rate, we'll go through the pictures. And so it doesn't last. I think that debate is largely been put to rest. Those of us who do a lot of this, I mean, she's actually now 9 years out and she has not lost it. But once you have fat in a year, it's going to be there. And even you have to be careful in premenopausal patients because it may then expand further if they happen to gain weight postmenopausally or through other means. That will expand, and so that can be a very challenging problem in a long-lasting filler. So lower face, and those of us who do a lot of lip filling will recognize that even on smiling, for that to still be evident indicates a pretty good improvement, again, 4 years afterwards. So how do we do it? Just quickly, fat transfer I do with a very gentle technique. Sid Coleman was, I think, the one that really is credited with popularizing a gentle aspiration and handling in general. And it's as I learned from Drs. Martin and Robert Glasgow for fellowship. But gentle harvesting, so I only do about 2 cc's maximum back traction on the syringe, on a 10 cc syringe, with a very small 3 millimeter cannula. And I just take my time and try to keep it alive. We then centrifuge it for 3,000 RPMs in 3 minutes. It's not been shown to be any better than telfa rolling or tea strainer, but it's pretty efficient and it's the way I was trained. It works well. I don't want to mess with it. So we then discard the stuff we don't want. We keep this nice central yellow fat, and we transfer it to 1 cc syringes and insert it with 0.9 and 1.2 millimeter cannulae in multiple passes, multiple planes for maximum viability and maximum proximity of the fat cells to blood vessels is the concept, and it seems to work well. We particularly inject only withdrawal near the vessels. I will say that subcutaneous, superficial subcutaneous cheek, we may inject on advancement as well, but really, in particular, in the region of the infraorbital and supraorbital foramina, we're very careful to avoid the in temples, of course. So always on the side of injecting only withdrawal, that pretty much goes first, and that goes as well. And so it's just a slow injection of probably 2 passes in the cheeks per 0.1 cc, and on the infraorbital rim area, I'm probably doing 5 passes per 0.1 cc. So it's just a nice, careful, slow, methodical movement. Movement, which I think contributes to the viability of it. I think people who, sometimes surgeons can be, I think, kind of impatient and try to just blast it in there, and that probably contributes to some irregularities that people see. I've certainly had some irregularities, but it's really, really low. I mean, I think I've had 2 that I've had to adjust, 2 guys, interestingly, but it was very subtle. Neither of them was what I would consider disfigured or anything, but steroid injection and actually suction of another one for a very small area along the focal rim, but that's several hundred cases over 9 years. So I've been very happy about it. I wouldn't still be talking about it if I wasn't. And so it's inexpensive equipment. You can probably get everything that I'm showing here on eBay for $1,000. Very high satisfaction in our hands. It is durable and it's natural stuff. So a lot of people who just only want the natural filling prefer this. There's a little longer downtime, significantly longer downtime, of course, than with synthetic fillers, whereas it might be 2 days with synthetic fillers, unless you get a good bruise. I tell people usually 2 weeks for fracturing. So hopefully we'll improve that with adding PRP, as we'll allude to later, but right now I just tell people to conservatively just expect 2 weeks of social downtime. They might even still see some swelling after that for a few weeks, but they'll be presentable by that point. You may need to repeat it. I think it's less frequent than many would critics would say. I probably refill less than 10% of ours, and I just tell them they might need a touch up. There is a variability of uptake, and that's just part of the game. Humans are variable anyway. So I don't actually charge for a touch up, just facility, and if they want to come do it again, then we're happy to. And it's easily combined with other procedures, as we'll show. I like to wait a year, I have seen actually in a patient who was at 6 months, and others have talked about it, friends of mine, Sam Lamb with glass holes, where it may look like it's at a low point at 6 months, and then it seems to perk back up by a year. So I like to give it a full year, just like we see the skin improvement, probably not until about the 1 year point or later. I just don't want to take the chance of hitting it at the low point, refilling it, and then overshooting. So 1 year is the short answer to retreat. So combination with facelift, shaded facelift, and no lower blepharoplasty actually, and by filling 3 cc along the infraorbital rim, anterior and lateral cheeks. She's smiling, so I apologize. That of course gives it an even better appearance, but she was very happy when it did. There she's not, and I think you can still see a nice improvement of the infraorbital rim and disguising of the infraorbital fat pads. In addition to the typical straightening of the jawline. So that was part of the effect, but I wouldn't, at least half the effect now for me is treating the mid-face. And then so a few examples, like I was saying earlier, mild, moderate, and more advanced atrophy. She's kind of a mild atrophy patient, and we only did the 3 cc's, which is typical along the infraorbital rim, 2 medial and lateral deep, and then 1 superficial, and then 3 anterior, 2 lateral cheek. And a little bit of lateral canthus. And so she didn't need much. She already had pretty good skeletal support, and I was very happy with the results. And so she, more moderate atrophy, and we did do some superorbital rim filling with her, 1 cc medial and lateral. And we actually did the temples in her, 2 cc's. We did a typical 3 in for rim and anterior lateral cheek. More advanced atrophy in this patient, who's a cancer survivor actually. Again, if you were to lift this brow, then how high would it be in this picture then if I had filled it and lifted? So I don't think anybody would consider lifting that further. It almost looks like she had a brow lift. But again, by restoring that highlight there, I think that makes us perceive this as a greater distance, or at least more pleasing to me. So, and this is without blepharoplasty, without brow lifting. And in this case, without actually laser resurfacing. So 1 cc medial and lateral, superorbital rim. I wish I'd done more, but the nice thing is you can always touch up with HA fillers. Is my preference in that area. 4 cc's in the temple, and I think that while my number got in the way there, I think that she's got a nice improvement of her temple and mid-face. So at least half of her result to me anyway is in the upper 2/3 of the face, and the lower third is typical improvement for facelift. So one more advanced atrophy case, in this case would be 2 cc's unilateral super over rim, and that's probably the most, the biggest difference that I've been able to achieve with super over rim, trying to create parallel lines, as described by Robert Glasgow, between the lid margin and your new sort of subbrow skin fold or reflection onto the pretarsal skin. So in typical infrared rim and lateral cheek. So basically the main thing that's changed in these is increased amounts of superorbal rim for the mild, moderate to advanced atrophy. And the other thing I want to point out is that without any lateral subcutaneous brow lift or anything, that inflation of that brow creates a little bit of lift of that tail of the brow. So what will be helpful in the future? I mean, people are already using PRP. I haven't yet for most patients. Together with fat transfer, people would advocate anywhere from 10 to 1, 9 to 1 and 8 to 2 as far as number of, as far as ratio of fat to PRP. I may start doing that in the cheeks and just try to tiptoe into it because I don't want to mess with what seems to be working well for us. And the cheeks are an area that are easily corrected as opposed to the periorbital area. Hopefully next year I'll be able to tell you what our results have been. Stem cells, so maybe that accounts for the improvement in the skin texture that we tend to see at a year. Certainly they've been shown in animal models to increase the collagen thickness of the skin when fat is injected into the skin. And so whether we can modulate that through stem cell extraction methods will remain to be seen, but there does seem to be improvement in the skin texture about a year or so after fat transfer. So I think there's a lot in the future for fat transfer. Just briefly, the type facelift we do is the deep plane facelift. We go beneath the SMAS. The only reason I really bring it up is two things. That it pulls, when you lift the platysma while it's still attached to the skin, first of all, creates a nice durable tool. But also when it moves the skin in a unit with the platysma muscle, I feel like you get a better improvement in the skin itself. So that's why we do that, durability and the natural result. And so, again, this patient who didn't have laser resurfacing, but still got, I think, very nice improvement in the texture by lifting the skin along with the platysma muscle instead of what I previously did, which was a SMAS suturing technique and then redraping the skin. You're not getting the same pull in the skin because as we learn, if you put tension on the skin with the lift, too much tension, of course, it won't survive. That's the point at which we enter into the deep plane. So right about with the platysmal insertion into the face. Just a brief video. I'll belabor it, but I should speed it up for us. This just shows the skin's already been elevated, and we're just showing the entry point of the deep plane. Just kind of a nice plane that it's nice to show, yeah. And right there is our entry point into the deep plane or beneath the platysma muscle that's made with the template. And you can see the undersurface of the platysma up here, and then the deep fascia down here, and the facial nerve is well protected in that deep fascia. So, okay, go ahead, advance. And so the reason I bring that up partially is that we have to get beneath that if we want the fat to survive. And so I'm then injecting the fat beneath the zygomatic musculature in the mid-face. Along the infrared rim, I'm not really dissecting very far that way, so I don't have to worry about altering the depth of injection there. We make some other alterations in the lower face. So then combining with laser resurfacing is easy. I feel a little heretical speaking about fractionated CO2 with Dr. Gold sitting here, but because as I was reviewing all the literature on fractionated CO2, the first name that came up in the Luminous brochure was Dr. Gold. So at any rate, so we owe him a great deal of thanks for determining what are good and safe parameters for this. I actually acquired it because it seemed to be the highest power and therefore best ablation to coagulation ratio and low risk, and that's what I really like to try to stress. It's pretty fast as well because of the high power, and it was economical. It might have originally been, I don't know, 150 plus, maybe 200,000, and we're able to get it for 30 or 40. So that works well for our kind of smaller market in Ohio. So the settings we use together with the facelift are with the Active FX handpiece. We use 80 millijoules and a couple passes. 6 density in the non-undermined skin. While a friend of mine has this, he recommended doing the flap, so the elevated skin, not the deep plane area, because that's included in this non-undermined skin. I had some delayed healing, and so I'm not lasering the flap, the isolated skin flap at all anymore. And eyelids, of course, we use corneal shields, and these are the settings we use for that, in case anybody's interested. So again, we don't laser the flap and don't do the neck as well for the same reason. They're just worried about the fragility, particularly the neck and elevated base without the plexus muscle beneath it. So to play on this, and this is something I like to show patients, just the nice tightening effect that you get. Those of you who do laser resurfacing, I've seen this many times probably, but the first few times I still am impressed by it. You do one pass and it lays down this nice grid, and then you lay down a second pass, you do a second pass, and it really just tightens it further. So this is, I'm in a private practice setting, and so I don't have a lot of volunteer patients. This just was kind of a serendipitous result where she wanted originally to do laser resurfacing, but forgot to do her hydroquinone at 2 weeks before, which we require. And while she begged me to do it, I said, we don't want you to turn dark. And so she relented. And so we did the deep plane facelift and we did volume restoration as well. But at any rate, we did the facelift and neck lift and without laser resurfacing. And she got, I think, a nice improvement of the lines around the more lateral parts of the periocular area, which we would expect to improve the lift, but still had fine lines. It's not great to see there, but you can see the pigment, I think, changes. But suffice to say, she had a nice improvement. She's only, I think, a month or so out at this point, so she's a little pink still, and that's going to go down. And now, of course, she wants the remainder of her face laser because she loves the improvement in the periocular area. So in summary, I'm lifting brows a lot less, certainly, I think, than facial guys of the past decade or two, and doing much more filling of the brow. Fat transfer is nice if I'm already going to be in the OR and giving the patient a week or two of downtime. Certainly, we can substitute fillers for pretty much everything that I showed. It's natural. A lot of patients appeals to. There's longer downtime, 2 weeks versus 2 days, as we're saying. It's easily incorporated with other procedures, or a standalone, and I have done many patients as a standalone. Have to be judicious, just like with all line restoration, and be gentle. Laser resurfacing can easily be incorporated as well. I just don't like to laser the flaps or in the neck. So that's worked well for us, and I appreciate your attention.